good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to yet another episode of ACNS webinars. The speaker for the first session of today's webinar is our honored guest from the USA, Professor Ajay Vaklu. Professor Vaklu is a professor at the Tufts University School of Medicine, Beth Israel Leahy Health, Leahy Hospital and Medical Center, USA. Dr. Vaklu has been the principal investigator or co-investigator on numerous grants from the NIH, AHA, private foundations, and industry. He has over 500 publications, presentations, abstracts, including 2 books on stroke treatment and more than 250 peer-reviewed articles and book chapters. He has been recipient of numerous scientific awards and honors, and he was named a fellow of the AHA and Stroke Council in 2009. He holds several US patents for neurovascular devices. Dr. Vaklu pioneered the field of flow diversion, the newest technology for minimally invasive treatment of brain aneurysms. He has been the central figure in the commercial development of this technology. He was also the first to introduce and publish the concept of using a stent to remove an embolus for the treatment of stroke, which is currently the standard endovascular treatment for acute ischemic stroke. He has been a founder and has served as CEO and CMO of various medical companies. And we are extremely honored to have him today at our webinars, and today he'll be talking about his favorite topic, which is flow diversion from bench to brain. The speaker for the second session of today is our honored guest from China, Professor Chao Tianji. Professor Tianji is an Associate Chief Physician, Associate Professor, Deputy Director of Department of Neurosurgery of Tangdu Hospital of Air Force Military Medical University. He is also the Vice Chairman of Youth Committee of Neurosurgery Board of Chinese Medical Doctors Association and Brain Disease Prevention and Control Committee of Shaanxi Provincial Health Association. He was declared as the champion of National Neurosurgery Skill Competition of China International Exchange and Promotion Association for Medical and Healthcare consecutively for 2017 and 18. He received the Young Doctors Award of Wang Chongcheng's Annual Award of Chinese Neurosurgeon 2019, as well as he was a runner-up of the finals of the National Neuroendoscopic Surgery Case Competition 2020. We are extremely honored to have him today at our webinars, and today he'll be talking about a modified technique to harvest integrated zygomatic arch temporal bone flap, a clinical experience. The chair for the second session of today is our distinct faculty from Japan, Professor Takashi Sugawara. Professor Sugawara is the Associate Professor at the Department of Neurosurgery, Tokyo Medical and Dental University, Tokyo, Japan. His clinical interests are focused upon skull-base surgery and craniofacial surgery, and he is an important member of the Japanese Neurosurgical Society. He has published several articles in leading journals and book chapters, and we are extremely thankful to him for accepting our invitation to chair this session of Professor Chao Tianji. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, who is coming in for Professor Bokardi, Professor Shubin, who is the Vice President of the ACNS. Professor Shubin, please.
Okay. Professor Vaklu, I think he is a world-famous expert, not only a great neurosurgeon, but also inventor, I think. So we invited him to present his great ideas. So Professor Vaklu, so time is yours.
So first of all, I want to thank you, Professor Shubin. I want to thank Raja and the ACNS for this kind invitation. And I apologize for the last time that I missed my presentation. I really am very sorry. Today, I thought that I would go a little bit deeper into the science behind the flow diversion. Last time when I was invited by Professor Shubin, and Dr. Hiroshima, I talked about the posterior circulation and the purpose of using flow diverter for the basilar trunk aneurysm. Today, I will talk a little bit, like I mentioned, about the basics of flow diversion. You see here a anterior choroidal artery aneurysm that has been treated, and on the right side, you see a follow-up where you see nearly complete disappearance of the aneurysm and preservation of the anterior choroidal artery. So what is the driving science behind this? What has enabled these observations, and what has enabled these findings? I want to thank for this presentation the financial disclosures are mainly around NIH. So we received from the National Institute of Health in Washington several R01 grants to explore this technology and come up with the science. I do believe that flow diversion is an excellent example of the integration of physiology, engineering principles, and biology to solve a very complex medical problem. And there are other problems. I think that this is the approach, I think, which what I stick to. And I do believe, having seen this field or observing it over the last nearly 40 years, that flow diversion is probably the most scientifically studied and scrutinized endovascular treatment for brain aneurysm. And I do strongly believe, and we are working on other similar technologies that is superior to endosaccular closure, and I dare to say even in certain conditions superior to surgical clipping. I think we are enabling by introducing this implant, the flow diverter, to have the body repair itself. Those of you who are interested in digging deeper into the flow diversion, there's a book published by Dr. Min Park and his colleagues in 2017, and we were invited to talk about the history as well as the surpass device that we generated and is now FDA cleared. Of course, on such a long journey, there are a lot of students, a lot of postdocs, and my colleagues that need a special thank. And especially I want to thank my family as well here, my wife and my kids, and my twin brother who is an architect in India. So I want to thank them to support me on this journey. And these are my colleagues here, Dr. Lieber, who was a critical person in this. He is a biomedical engineer working almost now for 30 years with me on this project, and my colleague neurosurgeon from Nijmegen, Dr. Joost de Vries, and other colleagues who have been very important on this journey. Now, one thing, and if there are younger colleagues who have logged in today, my personal experience has been that observation in our field is important. We are surgeons, live from eye. We live from eye and we work with our hands. So the eye is in this process of observation critical. So whenever you see something that doesn't fit, don't blame yourself, but ask yourself, what is it, what I'm seeing, and why doesn't it work? So instead of pushing it away, dig deeper. And that's how flow diversion was born. And I will give you a little bit of the background. And then another project that I was driving was also an accidental finding back in 2006, was the stent retriever for clot removal. And it was an accident. I was telling to Raja, while I was removing coils with an enterprise stent, and then we found out that we could remove clot as well. Now, you know these findings better than anybody, that the 5-year cumulative rupture rate with large and giant aneurysm is dismal in the anterior circulation, but in the posterior circulation, even more so. And these studies have shown that there is a room for improvement. And then the phases score that I use generally for my patient shows that there is a huge correlation for rupture risk between the size and the location of the aneurysm. So when we look at that, we realize that we have to, in endovascular world where currently coil technology is failing, has failed, there's a role for further improvement. These are another way to look at it. Here, the plotted phases score with the risk or predicted probability of aneurysm rupture and the dramatic increase once the aneurysm reaches a size of 20 or 25 millimeter. Now, in the posterior circulation, things look a little bit more challenging. As you see here, for basilar trunk aneurysm mortality, up to 80% in over 5 years, if the patient harbors a basilar trunk aneurysm. And the treatment is really challenging, whether it's surgical or endovascular. And I think there is a strong role for flow diversion there as well. Now, if we talk about endovascular treatment for brain aneurysm, what are the most important aspects? I think personally, the most important aspects are, besides the scientific issues, that is safety, predominantly safety and efficacy, the global needs. It has to be ease of use. It should be user independent, almost like taking a pill. And it has to be fast radiation dose, of course. And in certain parts of the world, economists, and Raja just talked to me about it, is very important as well. Now, there was a landmark paper here published from the UCLA group under Dr. Murayama, who put together the data over 10 years in their own practice. And what they found out that small aneurysms have very high, small aneurysms have a 5 to 20% risk for reopening after being treated with coils, and large aneurysms up to 35%, and giant aneurysm, if they're treatable, over 50% for reopening and recanalization. So these are hard data. And this is a case I did with my colleague in Thailand. And you see a ruptured MC aneurysm that was treated, and 3 months later, it's already showing some recanalization at the neck. And this paraophthalmic aneurysm shows definitely a significant reopening due to coil rearrangement and coil compaction. So why does that happen? And we looked into that. This is the mathematics behind that, and published in 2007. If we use the data from MRA for flow data here from Ensman's group, and we apply that to a basilar top aneurysm, you see this is the illustration of a simplification, an illustration of the basilar artery here with a diameter of 3.6. And this is the top of the aneurysm with the neck. So if we develop a ratio between the neck and the diameter of the artery, the largest for this model neck size would be the size of the artery. That would be a ratio of 1:1. And we apply the mathematics, so the energy that's translated from basilar artery to the surface of the neck of the aneurysm, and plot it out like that, and then calculate the maximal forces with each pulse cycle acting at the neck. It would be the highest at a ratio of 1, which means, again, like I said, a ratio of 1:1 between the neck surface and the cross section of the basilar artery. And the forces are with each pulse cycle close to 300 dynes. What does that mean? That means with each pulse cycle, the size of a small dime is hitting the coil mass. And that explains very well why these materials that are placed endosacrally fail. And so the principle, what we look at it is fairly interesting. And that is that we are trying to create a clotting and scarring and endothelialization at the neck before hydrodynamic forces created fatigue of the implant. So that's the dilemma we are facing. So all the materials that go endosacrally have to withstand the hydrodynamic forces that occur with each pulse cycle. Now, the flow diverter is a completely different principle. What the flow diverter does is, this is a case we use 2 pipelines here across the supraophthalmic paraclinode aneurysm with a small blister here or an outpouching here. And we place 2 devices, and this is 6 months follow-up. And you see some endothelialization here. The aneurysm has clotted and has disappeared from this angiogram. So when we look back for studies and we look at what about reopening or recanalization of previously treated aneurysm with flow diversion, we find almost no literature, with few exceptions, that describe that through vasa vasorum, some of the aneurysms have reopened, and some of the problems have to do with the dual antiplatelet treatment as well. When we look into the coiling of brain aneurysm and go back, and then you will realize there are over 2,000 publications only on reopening and recanalization and regrowth of aneurysm after previous endosacral treatment. So you see the difference is tremendous. And this is a paper in neurosurgery published by the Puffs group, showing that the long-term data here, 5-year data, shows a progressive occlusion of the aneurysm to complete neck occlusion Raymond 3. And the outcomes in the Puff study that enrolled large aneurysms was excellent, with a modified ranking scale less S2 in over 96% of the patient. Here is a case that I did with Dr. Peter Kahn, who was at that time at Baylor, a dissecting aneurysm in a young patient who had chronic headaches. And as you may see, it's a fusiform segment here involving the M2 division in this young child. In the old days, and still some places people master this treatment. This is from Coase and Spetz's book, where this aneurysm was treated by using a short bypass, a high flow bypass, and with very good results. But there are not many neurosurgeons who can master these kind of surgeries anymore. So what we did is, in this young man, we placed 2 flow diverters here overlapping, and then the narrowed area was then treated with a balloon mounted stent. You see there's some residual narrowing left at the area of the dissection. And then after the treatment, you may see that some filling of the aneurysm here on frontal and lateral plane. And then at 6 months follow-up, you see the narrowing has a little bit progressed. This was a drug-eluting coronary stent, but the aneurysm is completely closed with the perforator lenticulostriate, here lateral lenticulostriate, as well as the distal M2 branch is widely patent, and the patient is asymptomatic. Some reduction in flow due to the flow diverter placement in the A1, which the contralateral side has taken over. So where did the journey start? The journey started when I was back in Freiburg in the late 80s, where I was working under Professor Schumacher and some other folks here, my student, Frank Schellhammer at that time, and with Dr. De Vries, who created the aneurysm. And then what the idea was to prevent herniation and displacement of detachable balloons from aneurysm. So I was working using stent, Strecker stent at that time, to keep these balloons and coils inside the aneurysm. That was the plan. And to my surprise, when we were treating these aneurysms, this is before the stent, this is after stent, this is 7 days later and 6 months later. And this is the what we call knitted Strecker stent. To my surprise, these aneurysms would go away without the use of the coil. So I was wondering what is happening. So we did histology. And this is now before, and then here you see after placement of the stent. And this is the artery here, and this is the venous pouch in this dog model that was sutured here. And after placement of the device, and 6 months or 3 months later and 6 months later, you see clotting of the aneurysm and then scarring of the aneurysm with a nice coverage by a neo-intima that creates a circular structure across the artery. So that was something that came to me as a surprise, and we were wondering. By training, I was not at that time a flow mechanics. I had to take some classes. So we did then high frame rate DSA, and you see before and after that part of the aneurysm wouldn't even fill with dye. And that was some interesting observation. Then first we thought it has to do with the metal alloy. So we took, instead of chromium cobalt here, we took other alloys, we redesigned the devices, and we found in all these phenomena that was irrespective of the metal alloy used. We had less intimal hyperplasia with nickel titanium, as you see here. This is a nickel titanium device, and up there, this is a tantalum device. So there was something as far as the intimal coverage is concerned that was related to the alloy used. But in general, the observation that the aneurysm is closed was with all these alloys the same. And then I moved to United States. I came to Spetzler, spent there a year, and then from there to Buffalo, New York with Nick Hopkins. And I met an engineer, Dr. Lieber, and we started working together. And at that time, what we used was laser-induced fluorescence technology for semi-quantitative assessment of the flow changes in the aneurysm and in the parent vessel. So what we did is we basically created very simple sidewall aneurysm and injected then laser light that's then shined by laser sheet, very thin laser sheet. We cut it. And what you see then is before filling of the aneurysm with the laser dye, with each pulse cycle and then washing out. And then when we placed the Strecker stent, you see there's a flow stagnation in certain parts, and in other parts of the aneurysm, there's still some commotion. So we plotted that out over the entire pulse cycle, and you see there's a very volatile flow within the parent vessel and the aneurysm over the entire pulse cycle. And this is the eye of this complex flow that moves from proximal to the distal side, and then it hits the aneurysm lip and separates in 2 points. One goes down down the stream, and the other enters the aneurysm and circulates it, and over an entire pulse cycle, washes out then out of the aneurysm. And this is a very complex behavior, and that explains also why neurosurgeons often, when they operate, see this atheroma, atherosclerotic changes within the artery. It's a complex process that creates an intimal damage with secondary deposit of fatty streak, like similar to what we see in the carotid bifurcation. Now, what we then did is we introduced various Stryker stents here with various what we call porosity. So porosity means here metal-free area 85% and metal area 15. And then what we found out when we adjusted the Walmsley numbers and Reynolds numbers, which are two main characterization of arteries, of flow in arteries, to vertebral artery flow, we found out that around 70%, here 76%, there was a significant stagnation in the aneurysm and some washout in the distal part. But when we moved from vertebral artery flow to carotid artery flow, and that is what the lower column shows you, suddenly the entire flow domain became unstable. That told us that we have to adjust the flow diverter or stent-like structures if we treat aneurysm to the local and regional flow. And that brought us to the concept of porosity. And the porosity, the sweet spot where we didn't get an occlusion of side branches and yet optimize the occlusion, was around 70%. So 70% was the magic number. And this is then CFD studies that followed, and we published that later. Computational fluid dynamic study have the advantage that you can simplify things. You can basically remove certain parameters, create new boundaries, and it's cheap. You need few students, you need a fast processor. At that time, these processes took very, very long because our computers were not as strong as today. But we learned something very interesting from the CFD studies, that the pressure difference between the parent vessel before placement of the stent and after placement of the stent was not different. The only thing that differed was the shear stresses or shear rates. Here, distal part of the aneurysm proximal before and after placement of the flow diverter here indicated by these dots. So there was a significant reduction of shear rates. And as you know, high shear forces create a damage in endothelium and initiate expression of metalloproteinases that basically break down the wall and create a growth of the aneurysm. So we had a couple of interesting findings. One finding, there was not an increase in pressure in the aneurysm, and that's something we expected because this is a closed environment. And there was a beneficial effect as far as bringing back the shear forces in the boundaries of the wall next to the aneurysm to the physiological range. After that, we dig a little bit deeper into that and move from semi-quantitative assessment of the flow to more quantitative. What we introduced then is called particle image velocimetry. So what we did is then we created again these aneurysm, simplified aneurysm. We then mixed into the fluid small glass particle the size of erythrocytes. And then we shined the light and applied two mathematical equations. One is called the Lagrangian and the Eulerian. And what this does it, and I will play it for you, what it does it gives you the velocity vectors as well as the amplitude. The amplitude of a school of particles, you don't see single particles, you see a school of particles before and after placement of the device. This is now within the aneurysm, showing you basically the high velocity vectors at the downstream, indicating basically the area of the high shear. And then we place these tubular structures across the neck of the aneurysm, and you see the whole flow domain changes completely dependent, of course, on the structure placed. So we found then that this technology is very helpful in optimizing these devices. Now, the easiest thing was to work with an implant that is a single layer braided technology. The reason for braiding technology to introduce was we could control all the parameters. This is a 96 braided, you see here in the center is the rod, and then the heads here rotate and create this tubular structure. And we could change the braid angle, we could change the the number of the wires, the thickness of the wires, and alloy. So we found out now a method to basically study the flow in the aneurysm, to study the flow alteration by introducing a system called the flow diverter. And I will come to that in a second. And we could control all the parameters of this flow diverter. This is one of the prototypes. Of course, we tried many others. With people ask me often, did you change the structure of the wire, change the direction, made some wings, made that on the, we did it like 30, 40. And we found out the simplest way to address the problem was a single layer braided system. These are the various parameters you hear in the literature when we talk about a flow diverter. Is the braid angle. This is your beta. This is where two wires cross each other. We talk about the thickness of the wire, the length of the device, the diameter of the device. These are the few simple things. Of course, the technology is moving fast. You are talking about biosurface. You talk about DFT technology, where we are putting platinum within the chromium cobalt wire. So there's a lot that will happen. We are working on bifurcation flow diverters. So the technology, once born, is really a nice platform to further innovate and do. So we went with all these things to the NIH back in 2005, and the group found that the name we coined for this product was Flow Diverter. The group was, at that time, I was at the University of Miami, where Dr. Harros was the co-chairman at that time, and in radiology, Dr. Quenser. And we thought that Flow Diverter would be very attractive name for the NIH, and the NIH funded us, like I said, in 2003, and the second grant followed 5 years later to study these implants. So what we then designed is called a system model. What we do with the system model, we create a method where we can test these implants in using CFD, using animals, and then ultimately going first in man. So it becomes like a circular model, system model to optimize these products as we go further downstream. At that time, the accepted model by the FDA was the elastase-induced saccular model in rabbit. What we did is we tied the right carotid artery. We basically soaked the common carotid artery with elastase from porcine and stopped the flow into the subclavian with a balloon. And then you wait a few weeks later and you create here an aneurysm. And the nice thing is the vertebral artery then here on the right side serves as a surrogate for a perforator. This is an angiogram of the rabbit here. This aneurysm formed here. They come in different shapes and sizes. And this is the vertebral artery, and this is your subclavian artery in the rabbit. And then what we did is we created a vascular replica to test our devices. And then we stuck these various braided systems into this aneurysm. Once again, the vertebral artery served as a surrogate. And we attached the whole model to a pulse duplicator, and that's how it looks. So it's an artificial heart that's attached to this. So you can control everything. You can control the heartbeat, you can control the Reynolds numbers, and with that, you control the entire flow domain. So you have, again, in a vitro model, created a method to assess the devices, and you have the braided technology that gives you all the parameters that you can fine tune during the braiding. This is how it looks now. So not typical sidewall aneurysm. We call it semi-bifurcation aneurysm due to the high flow forces, because the artery comes directly out of the heart. So it is subjected to a very high rate. It is about 150 to 180 beats per minute in a rabbit. And this is an inertia-driven flow in this area next to the sidewall, which is a shear-driven forces. So here the devices were subjected to much higher forces, and that's a good model to test also the fatigue of the material. Now, what we could do is then using, again, particle image velocimetry to study what happens to the shear rates. Distal shear rates here before the device, it goes up with the blood flow during the systole, and then after placement of the device, reduction of the shear rates at the distal part. Same thing in the proximal part. Pulsatile flow, inflow, outflow. So the shear rates goes in one direction, and during the exhalation and during the deceleration in the different direction. And that's after device, again, flattening towards more physiological range. If you look at the shear rates plotted here, physiological range. So we were very happy. And then what we do is we created here different flow diverters and stuck into the model, and then start studying the mean hydrodynamic circulation. So the goal was, how can we optimize the flow reduction within the aneurysm without reducing the flow in the side branch? Again, the vertebral artery served as a surrogate for side branches. And as you see, for the mean kinetic energy in the aneurysm, so the translation of the energy from parent vessel into the aneurysm, there were 3 devices that we thought were very good. This is the control group, and this is the mean energy here. The group A, the device A, device E, and the device C were good. And when we look at the mean circulation in the aneurysm, the device A, E, and C were again good. This E and C were better than the A. So what we do is then we play tic-tac-toe. So we go from mean circulation, take the 2 best, and then from mean kinetic energy, we take 2 best, and we say, okay, let us stay with those 2 devices and go back into the animal, and of course, first into this in vitro model. And this is no device, and sorry, it's jumping. This is device A and B, and then we go back, like I showed, into the animal model. I have here a little bit of it. Yeah. So you see in the animal model here, the aneurysm here up there, the elastase-induced aneurysm model, and then the vertebral artery here in this video clip. I will stop it for a second. Right here, you see the aneurysm. And then after implantation, you see there's still some filling of the aneurysm right here. But the flow in the vertebral artery is maintained. There's some reduction in aneurysm. I will stop it here. And then you see 6 months later or 3 months later, the aneurysm is completely gone, preservation of the flow. And if we plot it and then do Fourier transformation of the graphs, you see here inflow of the dye, outflow before the device implantation, and after placement of the device, inflow and outflow. So there was a significant reduction of the contrast going inside the aneurysm, but it means also that the contrast that goes out is also delayed. That brings us to a mathematical model. I don't want to bore you, but there are 2 components that are interesting and important. This is based, and this was created by Dr. Lieber, whose background is in mathematics as an engineer, and it's based on the flow equation back from the 40s from a British scientist. And it is basically the balance of convection and diffusion in the pipe. Convection is the stronger flow component, and the diffusion is the slower one, not to be confused with the diffusion in chemistry, where we talk about the semi-permeable membrane. This is convection diffusion. To give you an example, that would be, convection would be if you open up a main door and you open up a window and there's a strong airflow through the room. Diffusion would be if you close the window, you leave the door open, and you still see some airflow because there are cracks in the windows, there are cracks or small outlets from the room. So that would be the diffusion. So the idea was, how do we switch a convective flow to diffusive flow? And that's how the mathematical model looks. Inflow, outflow, diffusion would be contrast goes in but stays. So what we are trying to do is we are trying to convert, by using flow diverter, the flow inside the aneurysm from convection to diffusion. So we designed 2 flow diverters, and that was the second part of the NIH grant, was very similar porosity, 70%, but the pore density, that means pores per square millimeter, was always double. And we wanted to see, has the pore density or mesh density have an impact on the outcome? And we did the rabbit study here at 21 days, 90 days, and 6 months. And what we found was very interesting. In fact, device 1 did as well as device 2. However, in the long term, the device 3 did better than device 2. So a finer mesh with the same porosity, as you may recall, I said the magic number was 70% porosity, so 30% metal, and the higher mesh density would be better to basically maximize the alteration of the flow within the aneurysm. And the nice thing is, when you plot the mean, that the device 3 showed a much higher rate of complete occlusion. And this finding basically is summarized here. So the best way to look at it is to take a checkerboard. You see on the left side, a checkerboard with 50 black, 50 white. So 50% metal, 50% metal free. On the right side, you have the same 50% metal and 50% metal free. That would be your porosity. And the pore density or the mesh density would be 16 times higher on the right side as compared to the left side. So how do we achieve a higher pore density? By just making the wires finer and finer. And that's what we did. And here are the studies, CFD studies. I thank De Boyle and the scientists from Belgium for these slides. This is a 3D data from a patient with a supraophthalmic aneurysm. And as you can see, there's a significant reduction with the number of the wires used. So mesh density, finer mesh density, as far as the shear forces are concerned, experienced on the aneurysm wall, as well as the shear forces experienced at the neck. So the entire reduction in flow is significantly higher when we move with finer mesh. Now, the other advantage using finer mesh, as you see here, from 48 wire to 72 wire, is that the construct, when you place it over different diameters of the artery, is less subjected to mesh density changes and structural changes. On the left side, you see horizontal diamond shape in a smaller artery, and then a vertical diamond shape if you place the device in the larger artery. To your right, a device, same device with 72 wires, and you see that the square shape and the number of the cells per square millimeter don't alter. That means higher number of wires, finer mesh is the way to go. We went then back to looking at what happens in the animal. So on the left side, you see after placement of the device, there's amorphous clot. And the interesting thing is, when you then wait, that the healing mechanism of the aneurysm is from peripherally to the device to the center of the artery, telling you that basically you do not need to completely occlude the aneurysm. It's enough that you stabilize the aneurysm, even if you have a little bit left at the entrance, because the healing mechanism goes from the perimeter of the aneurysm towards the artery. So the strengthening happens exactly in the area where the aneurysms normally rupture. And why is that so? It's very simple. You have a flow that goes all the way to the perimeter of the aneurysm before placing the implant. And when you place the implant, you basically create a mesh so the flow cannot reach the perimeter of the aneurysm. And that's dramatically the larger the aneurysm are, and you see that in your own practice. So what then happens to the area where clot forms, it turns over to collagen through sprouting of fibroblasts and other cells, smooth muscle cells. We see the same thing happening in the patient population. We have published from our group that initially there is not a complete occlusion once you place the aneurysm, but over time, there is a progressive occlusion of the aneurysm. And sometimes it takes 2 years, sometimes it takes 3 years. But the interesting thing is that unlike with the endovascular treatment, the intravascular treatment is basically progressive healing versus a fatigue of the material in the endovascular treatment. We looked into the CD34 cells. We wanted to see, is this coverage of the device really endothelium, true endothelium? And that was the case. So this is a true endothelium that covers the mesh of the devices. And you have a very good example from plastic surgery. This is an SIS biomaterial here, published in Wounds in 2003, a mesh that is meant for our collagen, for our tissue, skin tissue, for healing, that the cell elements grow. We do the same thing with endothelium. So you have the combination of flow changes as well as the device, the flow diverter, serving as a matrix for endothelial coverage. And when you look at the neointimal thickness that covers the devices, the interesting part was the finer the mesh to your right side, the 70 porosity device, to your left side, the 70 porosity device with 11 pores per square millimeter as compared to 18, which is almost double. What you see is the finer the mesh, the thinner the endothelial coverage. Very important when we are basically moving with this technology to smaller and smaller arteries. We are right now treating vessels of 1.5 millimeter that harbor aneurysm with flow diverters. And you will see in the next few years, further improvement of the device, further improvement of the alloy. The other advantage of using finer mesh is very logic, and that is as far as the perforators is concerned. So when you look at the perforator, when you look at the perforator on the left side in the fine mesh, there will be hardly any perforator that's covered by the device, and the perforators are indicated by yellow and red. That will go down, that will close. On the right side, however, with a more coarse mesh, there are at least 3 in the yellow perforators and 1 in the red, maybe a second one, that would be obliterated by coverage of the device. This is, of course, an illustration, a simplification, but what it tells you is that the way to go is a finer and finer mesh. Now, you may ask me, why don't we make already fine mesh right now? The problem is when we do braiding with the current materials, chromium cobalt material, nickel titanium, and others that are generally used, there is a threshold where they, under the tension, when we braid these wires, that these wires start fragmenting. The wires start fragmenting and the yield drops. So we need to come up with new alloys, and people are working with new alloys to first keep the visibility, and that's why DFT technology is being considered. We need to come up with new alloys also to go down to 20 micron wire diameter. Right now, our threshold is 25 micron wire. To give you an example, the hair size of a blonde woman is in the ballpark of 70 micron, of an Asian person with a thick hair is about 150 to 180 micron. So you see, we are already very, very deep into braiding technology and improving the braiding technology. And we test these things in the rabbit aorta. You see on the left side, a rabbit aorta where 2 devices were placed telescoping to cover the renal arteries and the lumbar arteries. And these are the requirements from the FDA to show that the perforators may not close completely. Once we had all that, we did our first patient with Dr. or Professor Benjutz in Heidelberg, and Professor Hartmann was the operating physician. It was a supraophthalmic aneurysm here, fairly simple aneurysm, of course, for surgery. But for us, the challenge was the posterior genu and the anterior genu of this artery that was significantly tortuous. So it made the deployment of the device very difficult. But the interesting thing is, you see, after placement of the device, there was a flow stagnation within the aneurysm. And you see, this is the part of the aneurysm that moved from convection flow to a diffusive flow. And convection is still here. And that is exactly, when you recall, when I showed you the particle image velocimetry, and when I showed you the laser-induced fluorescence, the changes that happen after placement of the device. So certain parts of the aneurysm take place in flow, that's a convection, and other parts start slowing down. And that's where the clot forms. That's where the scarring happens. So it moves from the perimetry towards the neck of the aneurysm. This is, you see over the entire pulse cycle, you see the chorioretinal blush nicely, indicating that the flow within the ophthalmic artery is preserved. And you see how long the stagnation within the aneurysm is prevailing through the whole venous phase. And this is 6 months later, preservation of the ophthalmic artery and complete occlusion of the aneurysm. Of course, you will see sometimes the ophthalmic artery occluding because there is no demand and it is supplied through the back door. And we hope that one day with the finer mesh and biosurface modified devices, we may have preservation of the ophthalmic artery and other branches in all of our cases. To summarize, this is a good aneurysm. This is the good aneurysm that was attempted to clip by Dr. De Vries, and there was a lot of calcification, so he stopped it. And you see on the 3D, there's a second aneurysm here distally in the M2 division. And I want to explain you what the flow diverter does in this case. So you place a flow diverter here, and that's what we did. And the 2 flow equations I talked about is basically the pressure gradient that drives the flow from the parent vessel here, M1, into the anterior M2 division. That's a pressure gradient between the right atrium and the left ventricle. The flow that goes into the aneurysm and washes out is a momentum transfer. It's a transfer of energy during acceleration and deceleration during each pulse cycle of the heart. So what the flow diverter does is it basically disrupts the transfer of the momentum of the energy during acceleration and deceleration, which is 10-15% into the aneurysm, enough to close it. And that's the result here. On the right side, 6 months later, you see both aneurysms are gone, and there's some narrowing at the entrance and preservation. Now, the narrowing is related to some fibrin products and material. We have looked into that in the animals also. And we hope that with biosurface modified devices, we may eliminate these kind of observations. So in summary, I think flow diversion is a very good technology if we select our patients carefully. And I think the success rate is tremendous. What it does, it disrupts the fluid momentum transfer during the pulse cycle into the aneurysm. So it converts convective flow towards more diffusive flow. It also serves as a scaffold that enables endothelialization and progressive remodeling of the vessel wall. And I think there is our unique opportunity to improve further the surface and the materials to enable a faster endothelialization. And groups are working on that. It's a very user-friendly technology. You don't need to, work on the aneurysm itself, but it requires training. There is no doubt. It requires also dual, and in some indications, we do monotherapy. In the posterior circulation, I do triple therapy with anticoagulation because of the presence of a lot of finer perforators. And our data shows that the morbidity and mortality in small aneurysms less than 2%, in larger aneurysms around 10% is acceptable safety profile, but we still can improve that. What about occlusion rates? We see occlusion rates dependent on the size, location of the aneurysm in the ballpark of 70% at 6 months, and further progressive, and that's important, progressive occlusion up to more than 90% over the next 2 years. Subgroup of fusiform basilar trunk aneurysm, like I mentioned, remains a challenge, but our data shows, in my experience, that we should treat patients earlier in the game than wait too long that before they present with modified ranking scale 3 or higher, because then the complication skyrocket to 30-40%. I mentioned these two things: improvement to biosurface coating. There will be improvement in visibility through DFT technology. And I think we are on the way to develop bifurcation flow diverter. With that said, I want to thank you for your audience, and I want to thank you for your attention, and more than happy to take questions. Here are some colleagues I met on this journey, and I want to thank them to trust in this technology and do this enrollment in the Stent study that was completed in 2022. And these trials, you know very well, I don't need to go into those. With that said, my time is out, and thank you very much. Thank you, Professor Shubin. Thank you, Raj, and the ACNS.
Thank you, Professor Waklu. What a amazing presentation, and I think it's a very eye-opening lecture based on the profound understanding of the hemodynamics, even the sears, in the sears behavior on the mesh of the flow diverter. I think you can turn the bench work to the wide adopt, really revolutionary concept, and now it's turned into a real treatment. That's I think your great achievement is.
Thank you so much.
Inspired us for so much, you know. Thank you.
Thank you, Professor Shubin. Thank you for the kind words.
Yeah.
Thank you very much.
Actually, you mentioned that the porosity of the 70% is a magic density. I think because we have some early staged like Circ stents, the mesh density is I think it's a denser than the pipeline. Like pipeline is around 30%. The Circ may be achieved 40%. So is it the crucial? Do you think the side effect of the first stents, the Circ stents is not so satisfied the result?
So what I think will be important is that we should keep the porosity high, like 70%. The silk is 60% porosity. So the metal is 40, you are right. In the silk, the metal is about, I think, around a little bit less than 40%. And in the pipeline, the metal is like 30%. What we need to focus on is the mesh density. So we have to make finer and finer mesh, while we shouldn't have too much metal. The less metal, the better, but we have to optimize the mesh density, because the impact of the mesh density on the flow is higher than the impact of porosity. That's correct.
Right. Thank you. Thank you very much, Professor Waklu. We can just admire and applaud your wonderful work from where you started.
Yeah, I understand that you want to present cellular scaffold for the endothelium. That's a final purpose, I think.
Yes. Thank you so much.
Thank you.
Thank you, Professor Shubin, for this wonderful comments, and Professor Waklu for this wonderful advent of technology. I would like to ask one question that recently Professor Pascal Jabbar was one of the speakers, and he showed us that when in a case of operating recurrent aneurysms, when you put a clip on a stent and you remove it, it comes back to its original shape. So can the stents actually withstand that pressure and come back to the original in the current state of the newer stents that you are manufacturing?
I think that the flow diverter, unlike stents, don't have radial force. They have crush force, because the thing is that the stents for the carotid artery and other stents were meant to have a radial force and expand the narrowed area. So when you place a clip, what happens is that the normal vessel stretches with the device. So the clipped area stays the same, but it stretches the artery, the healthy part of this artery. Now with a flow diverter, you won't be able to create such a force to overcome the narrowed clipped area. That's very, very difficult, because they don't have the radial strength or radial force to do that. So in braided technology, we talk about crush forces, because a braided system has a needs very low crush force to collapse. So we have to be careful. So I am very reluctant in a narrowed segment to place a flow diverter unless you have to do it. And if you place it, then it's probably better to go with a second device, like a coronary stent that is balloon mounted, and you can open up the narrowed segment. But you have to be careful that you don't rupture the artery, of course.
Professor Waklu, do you think there's some future for the absorbable stent? Because in the cardiac department, they are creating this absorbable stent, but I think for intracranial stent, we should make a very stable support for the vessel wall. So I think it's meaningless in neurosurgical department. What's your opinion?
Professor Shubin, thank you for the question. I think this is a very important topic. So I was in Val d'Isere, and I was approached by somebody who's working on bio-absorbable devices. Here's the problem with the bio-absorbable devices. One problem is that when you cover perforators, if you see particulation during the absorption period, these particles will go downstream and close the perforators. That's one consideration. The other thing is, if you place a device in the artery, the first thing what you will see is within few seconds, minutes, that there are fibrin, fibroblasts, there are cellular elements that attach to the material. So when you cover a perforator, you will see that. That's why patients get these light flashes when you cover the ophthalmic artery, because there's an activation of platelets. There are little fragments of blood that attach to it. Now, if they attach to a bioabsorbable, and you will see an absorption of the material, even if it happens like a sugar cane, sugar slowly dissolving, where do these particles go? Will they go downstream? And that's my worry. That's my concern.
Yes. Thank you.
So I agree with you, Professor Shubin. I would stay with the metal alloy, make them better through surface modification.
Yeah. So I think maybe we can create some partially covered stent, partially different density in the different stent, in the different location of the stent. So we can cover the neck, but we will spare the perforators.
Yes. I think there is a chance, especially for the basilar top area, where we have still challenges in endovascular treatment. I think that area, basilar trunk area, would be a great area where we should have what you are suggesting, a modification of the mesh density and alteration. Absolutely. There's a lot of potential there. I do agree with you. Thank you.
Thank you.
Thank you very much. Any questions, Liu?
Thanks, Raja. Thanks, Professor. Actually, I'm about to ask the same question, whether there will be a personalized flow diverter depending on the cases, especially for cases that have perforator around the aneurysm or from the dome of an aneurysm. Professor, may I know that would the higher porous density affect a larger perforator, especially in para-ophthalmic aneurysm that affect the vision? And my last question, Professor, do you think that there will be evolution into the needs of using double antiplatelet in the future flow diversion or any endovascular device used in the patient? Thank you, Professor.
Professor Boon Seng Liu, sorry. I think that's a very interesting topic. In fact, there are several studies right now going on, including the one from Phenox in Brazil, where they are using single therapy. So they're moving away from dual to single therapy in their biosurface modified devices. Same thing in the United States. There is a study going on from Medtronic on their new biosurface modified pipeline. There is a coming study from Stryker as well. I think BALT has another study coming up where we are trying to move away from long-term dual antiplatelet to single therapy, single antiplatelet therapy. And I hope that one day we could work only with aspirin. And right now at our place, we use Brilinta and we use aspirin combination, or sometimes Plavix or clopidogrel and aspirin for 6 months. I know in Europe, people use it for 3 months. We still use it for 6 months. And some patients, I use only Brilinta, but it would be wonderful. And I think their biosurface modification will be the next step in evolution. But I do agree, that's a problem right now, especially for ruptured aneurysm, blister-like aneurysm.
Thank you very much. Ms. Professor Kimura, any questions from you?
Oh, thank you, Roger. Thank you, Professor Bakuzo. I learned a lot so much. So regarding especially I also researcher performing the computation fluid dynamic analysis for the cerebral aneurysm. And but in treating using the flow diverter, porosity is also an important factor, as I know. But today I noticed mesh density is also very important factor to simulate the actual actual status after the stent placement. So my question is how accurate the simulated results reflect their actual status, because the stent placed in the especially so tortuous area, and the porosity in the side of mesh is really changed by the tortuous remodeling by staining. So does it reflect the actual status or not? I'm still worrying about it. Thank you.
Professor Kimura, thank you so much for the question. Very important question. So when we do bench work, we take a straight tube, and there, of course, the mesh density is very consistent. When we place around tortuous areas where aneurysms are located, the mesh density may change. The interesting thing is what we found out, sorry, that the larger number of wires, the finer the mesh is, the less it is susceptible to changes. So in other words, if you have a mesh density of 25 squares per millimeter in a straight tube and you bend it, it will move to 22, 23 to 28. But if the mesh is 17 or 18 and you do it, then it jumps significantly. And you see that in the aneurysm. When you inject dye, there are pockets where you suddenly see like a jet going into the aneurysm, and other places where the flow stagnates. So it's critical to get rid of these jets. And the jets are related to exactly what you are saying, Professor Kimura, that suddenly you have an opening in the cell, in the mesh, because the mesh density drops below 20, which is a critical number, below 20, and it's not effective. That's why many people place a second device.
Yeah, I see.
So we have, that's the problem. So what we have to do is we have to make finer and finer mesh with a very high mesh density. So the tortuosity of the vessel doesn't change your mesh density too much in one or the other direction. Does that answer your question?
Thank you. Yeah.
Yes.
Yeah,
I think it's because of the Bernoulli's principle. If you make it actually, if you make you created some jet flow when you make the blood flow more stenosis. Yeah.
Yes.
And Professor Waklu, another question is about the difference of mechanical animal or mechanical models and the animal models, because this aneurysm models don't have the self-healing mechanism. But in the human body, sometimes when you put the flow diverter, you can really cure the disease, because the human self-healing mechanism is amazing. Sometimes even I did the distal occlusion, decrease the energy loss in the aneurysm dome. Actually, it can be healed by human.
I agree. So what we are doing is, Professor Shubin, we are creating now a cell culture in arteries. So when we study that, we can study the cell elements that basically are in charge of closing the mesh. So we are working on that. It's very complex, problem to have cell cultures in in vitro. It's very difficult, but we are working on that. I will show maybe next year some of our early results.
Yeah, great.
Well, thank you. We are all looking forward to those amazing technologies that will bring into this field and change neurosurgery forever. We can conclude the first session, and maybe we can hear the final remarks from Professor Shubin.
Okay, thank you, Professor Waklu. We were invited you to be a guest speaker at this October's ACNS Congress. Please accept it.
Thank you so much.
Okay, great.
Thank you very much.
So today, I think more than 10,000 audience watching your presentation. Thank you.
10,000. That is a number we haven't
Yeah.
reached so far. So
No,
thank you very much.
sorry.
1,000?
400. 1,400. Yeah.
Right, nevertheless, not bad. Thank you very much, Professor Shubin, for arranging a good chat for this webinar. Now maybe we can move on to the second session, and I may hand over this podium to our second chair, Professor Takashi Sugawara, to say a short introduction and invite Professor Chao Tianji. Professor Sugawara, all yours.
Yes, second speaker, Professor Chao, is going to talk to us a lecture, fascinating title, a modified technique to harvest the integrated zygomatic arch temporal bone flap clinical experience. Professor Chao, right? I was looking forward to your lecture. Please go ahead, your lecture when you're ready.
Okay, I'm ready. Okay, hello everyone. It's my great honor for being invited by Professor Shubin to join the great webinar of ACNS. And thanks for the introduction of Dr. Kajer, and thanks for the holding of Professor Sugawara. I'm Zhao Tianji from Chengdu Hospital, Xi'an City of China. I believe many of you may hear about our city. Our city is the capital of the ancient China of Tang Dynasty. Maybe you must also hear about the terracotta warrior and the bell tower and the wild goose Pugado. So that's about my city. And the topic of my topic of today is a modified technique to harvest integrated temporal zygomatic arch bone flap. I named it TZ approach because my abbreviation of my name is ZTZ. So I named this a modification of subtemporal approach, TZ approach. First, I want to start my topic from the classical subtemporal approach. As we all know, it's a workhouse used for approaching the area around the posterior glenoidal process, lateral midbrain, and the petrous apex margin of tentorium. But the biggest problem of subtemporal approach is retraction of the temporal lobe, which may cause disastrous consequences if the temporal lobe was damaged by during the retraction. I use this picture to depict this approach. The temporal lobe is just like this wall. If you want to see the site over the temporal lobe, just like this wall, you have two choices. One choice is you stand higher, then you can get more sight. The second choice is you make the wall shorter, then you can get more sight. But making this wall shorter means you need to remove the temporal lobe. So we never want to do this. So another option is chosen often by the skull-based neurosurgeons to stand higher. So the roof of this approach, we can see from this picture, is the zygomatic arch. So if you want to stand higher to get more sight over the temporal lobe, you need to you'd better to remove the zygomatic arch. So how to achieve a lower view during the subtemporal approach? Early in the 1998, Dr. Altugo published this article. I used a picture of this article. This is a picture showed the 3D reconstruction of the patient after the surgery. We can see the posterior part of the zygomatic arch has been totally removed after surgery. So I think it may cause extensive bone loss by this method, but it will bring the surgeon and the patient the benefit to reduce the retraction of the temporal lobe. So it's an early method to remove the zygomatic arch. With the development of the skull-based anatomic approaches, a lot of skull-based approaches require removal of zygomatic arch, such as OZ approach and subtemporal zygomatic approach and infratemporal fossa approach, ITFA. OZ approach is an classical approach and a widely used approach. To take the 3 pieces of the OZ approach, for example, we can see we need to remove the zygomatic arch as one piece of bone flap. So, but by doing so, we need a very large incision to expose the anterior part. That means the zygomatic front process. So the incision is very large. In the subtemporal zygomatic approach, if you want to get a more lower view from the skull base, you need to remove the zygomatic arch, just like the picture showed by this article. Based on the classical subtemporal approach, the author removed the zygomatic arch to gain a very good view. But is this surgical angle a very good surgical angle? So we use this 3D reconstruction picture to show the zygomatic osteotomy, which can bring the neurosurgeon this surgical angle. But I think this is not a very good surgical angle because it has a longer surgical route compared with this angle, and I don't think it's a very good method to remove the zygomatic arch in this part during the subtemporal approach. Besides, if somebody want to remove this part of the zygomatic arch root by remove this part of the bone, when you want to fix the zygomatic arch in the end, you will find you have no place to no site to place the collecting plate in the end. So it's a problem. In ITFA, we can see this picture is a picture from Dr. Fukushima. Dr. Fukushima divided the ITFA into 3 parts: anterior part, middle part, and the posterior part. In the anterior ITFA, we can see the incision is also very large. Dr. Fukushima indicated that the incision should large enough to expose the anterior part of the zygomatic fascial foramen. is here. So the incision is a large one, and in the middle ITFA, Dr. Fukushima said you need to do condylectomy and remove of the zygomatic root. But just like I said before, if you remove this bone, you'll find that the sectioned zygomatic arch will have no place to fixation in the end. So how to remove zygomatic arch with less invasive way and with less bone loss and easy to perform? So I always think about this question. So as a result, we put forward the integrated temporal zygomatic arch bone flap, the TZ approach. We can harvest bone flap which consists of the temporal bone and the zygomatic arch together, just one bone flap. So I will introduce the merits of this this method. So first is the incision. You can see we don't need to expose the most anterior part of the zygomatic arch. So the incision is not a very large one. So I think it's a little bit less invasive because we don't need to expose the anterior part of the most anterior part of the zygomatic arch. And maybe sometimes straight incision is available when there is no need to harvest the deep temporal fascial flap. Second, about the bone flap, we can see the anterior section is about the middle of the zygomatic arch, and we can see that the mast muscle is attached to the zygoma at this position. So our method will never affect the mast muscle on its adjacent is attach point. So this method will never affect the true effect of the true function of the patient. And go back to the surgical angle. I just said this angle is not a very good one because it makes the surgical route a little bit longer. In our method, we can see we just remove this part of the zygomatic root. So it also it is a little bit shorter than this type of zygomatic osteotomy. So I think this manipulation is better than this one. And to the craniotomy, I will introduce the craniotomy procedure with this picture. Firstly, we can make two burr holes. This is the first one, and this is the second one. The first one is just medial to the zygomatic arch, just lies in here, and the second one is at the posterior to the zygomatic root. And firstly, we make a burr hole here, and until we see the temporal dura, and then we make the second burr hole. Then we use a drill or a keratotomy to connect these two burr holes. Then other procedure is just as usual. So the bone flap is harvested with the temporal bone together. And by doing so, we this procedure do not affect the temporal mandibular joint (Tianji) because we left a thin bone just above the TMJ, and we achieve the lowest view angle at temporal base. when we perform closure after the in the end of the surgery, it also have a lot of merits for this manipulation. First, there is no need to place connecting plate at the posterior part of the zygomal arch because this bone just acts as the plate, and that will also bring less expense for patient. And the procedure is quick and simple, and there is less bone loss, and less dislocation because there is just only one section of the zygomatic arch, and there is less cosmetic problems. The clinical application of TC approach, I think it is very suitable to be used in subtemporal approach for the posterior clinoidal region lesions such as high positioned basilar tip aneurysm and petroclival meningioma and glioblastoma, and it also and the tumor involving posterior part of capital sinus or macroscope, such as trigeminal schwannoma and invasive meningioma and glioblastoma. I believe this approach is also suited for ITFA because to treat the tumors involving ITFA. Inferotemporal fossa, such as trigeminal schwannoma, invasive meningioma, and even for bypass surgery. In the subtemporal approach, we can see in this picture with the aid of the Osrix 3D construction software, we can see with removal of this part of the zygomatic arch root, we can achieve more forward to anterior clinoidal process and upward to posterior clinoidal process, surgical view, and manipulating angle. The increased manipulating angle is about 13 degrees. I will show a case. I will show a lot of cases using this approach. First, case one is suprasellar and petroclival glioblastoma. I chose the subtemporal and quasi approach. You can see this lesion invaded the posterior part of the posterior fossa and the suprasellar area. In the T2 image, we can see that the PCA and its perforators were encased by the lesion. So we need a very good view and manipulation angle to handle the lesion at the utmost pole. This picture shows the procedure of craniotomy. We can see these are the two keyholes I mentioned before, and with the craniotomy we can harvest integrated flap with the temporal bone and the zygomatic arch root. So this is the bone window, and when we performing the quasi triangle draining, we can see we achieved a very flat view from the subtemporal base. This is the end of the draining of the quasi triangle. So use this video, short video, we can see the benefits of this approach for treating this lesion, for resecting of the lesion that at the uppermost pole. After removal of the lesion or at the we perform we go upward to the we go upward. We can see this is trochlear nerve, and this is the incised tentorium. We can see this. This is the oculomotor nerve, and this is the lesion superior to the oculomotor nerve. So so we adjust the microscope to get a better view. Instead of retracting the temporal lobe, we can see by adjusting the microscope, we can get a better view of the lesion that superior to the oculomotor nerve. After resection of this part of lesion, we can see the PCA and its perforators. But at this time, we can see the hand of the surgeon may obstacle the surgical view. So we need to further adjust the microscope to use this corridor that's caused by the removal of the zygomatic arch by our method, and we can see the perforators and the lesions that medial to the PCA and its perforators. We further adjust the microscope. Well, the perforators and the PCA and the lesions are can be easily dissected with this corridor. And the retraction to the temporal lobe is very gentle. So with the sharp dissection, we can remove all the tissues, all the lesions, medial and superior to the oculomotor nerve. The removal of this part of the zygomatic arch root creates a very good surgical view and a manipulating angle for this surgery. This is the end of surgery, and the perforators and the PCA are preserved very well. Well, these are the post-operative images. We can see that the lesions are resected totally, and the temporal lobe was protected well. No PCA-related complications happened. This is another case. It's a calcified petrous apex meningioma. Because of the lesion is very hard and tough. So we believe the TZ approach is suitable for is useful to be added during the subtemporal approach to view and manipulate the utmost pole of this lesion. So the patient presented temporal palsy of the right oculomotor nerve immediately after surgery, but she completely recovered at 6 months. This is the post-op image of this patient. The tumor is totally resected. And the third case is a dumbbell-shaped recurrent trigeminal seminoma. We can see that still because of the recurrence of this lesion, so the utmost pole of this lesion is very adhesive. So we still need a very good vision and surgical corridor to do sharp or blunt dissection at this position. So I think TZ approach is also useful in this situation. So we can see subtemporal approach by using subtemporal approach plus TZ approach. The lesion was totally removed and the temporal lobe was protected very well, and the patient did not have any neural deficits. For ITFA, we can see by these 3D reconstruction pictures, here is the operative target of ITFA. This picture shows the traditional method of ITFA, just depicted by Dr. Fukushima. The zygomatic arch was removed at this part. So by doing so, the neurosurgeon can approach the infratemporal fossa and the pterygopalatine fossa area. But in our approach, we can just adjust the microscope a little bit posteriorly. We can also approach the infratemporal fossa and the pterygopalatine fossa. So we can approach the lesions around this area. This is another dumbbell-shaped trigeminal schwannoma. We can see this tumor invaded the middle fossa and the infratemporal fossa. I think it's a very good a very good indication for our approach. We can see during after removal of the zygomatic arch by our method, we can see directly the tumor. This part is this part of tumor lies in the middle fossa, and this part of tumor lies in the infratemporal fossa. This is a cavity after tumor removal. This patient gained a total resection of the tumor. The last case is an extensively invasive meningioma. You can see this tumor invaded the anterior fossa, middle fossa, posterior fossa, cavernous sinus, and the infratemporal fossa, sella tessica, and the pterygopalatine fossa, and the sphenoidal sinus. It's very extensive invaded. So we chose the extended frontotemporal zygomatic approach. We need to gain the frontotemporal and the subtemporal and ITFA surgical view. Compared with the traditional approach, we can see traditional approach is during the closure. Traditional approach needs 5 collecting plates to fix the bone flap. But in our method, we just need 4 collecting plates to fix the bone flap. I think it's better than this one. And for the exposure range, we can see these 2 methods may have similar exposure range, but our method will achieve lower view at the posterior part of the bone window at the temporal base, just by removing of this part of the root of zygoma. So we can get a better view at this site. This picture shows the middle fossa, infratemporal fossa communicating area exposed with zygomatic arch removal by our method. Because of the severe adhesion of this tumor with nerves. So for in this patient, we performed subtotal resection, and by doing so, this patient has no ocular motility disorders post-operatively, and she live a good quality of life until now. It's almost 4 years already. So a summary for the TZ approach, I think is a minimally invasive zygomatic automate technique. We can achieve better subtemporal view with minimized retraction of the temporal lobe, which make fixation of the bone flap more convenient. And this method is quick and simple during both squaring ultimate and closure. This approach has less bone loss, less dislocation, less cosmetic problems, and less expense for a patient. I think it's suitable for both subtemporal. This method is suitable for both subtemporal approach and infratemporal fossa approach. Well, that's all. Thank you. Thank you for your kindly attention. Thanks.
Okay, thank you for your showing your great experience and giving educational lecture. I have some anxiety about this procedure, and one is, as you mentioned, mandibular joint injury, and also second one is external auditory canal injury. Do you have some experience of this kind of injury complication?
Okay. Thank you for your comments. And for the TMJ injury, just like I said in the before, because we left we left a little bit thin bone just above the TMJ capsule. So in the patients I performed with this approach, we never find the injury about TMJ. Even we can't we can't leave the thin bone above the TMJ. You won't cause TMJ injury when you did not open the TMJ capsule. So I think it's not a problem. And I didn't hear. I didn't get the second. Excuse me, Professor Subara. Another. You means another injury about the site is
externally auditory canal, like.
Oh. No. We never heard external auditory canal. Okay, thank you.
Okay, and actually, I understand because the mandibular joint was kind of otherly medial part from the zygomatic root of zygoma, and if I we injured just outside of the mandibular joint, I think there is nothing happened.
Yeah.
Okay. And also, I think my understanding of your approach, I think you use this approach for the lesion of the anterior and the high position, because I mean I have never removed the zygomatic arch for the anterior petrosal approach, because usually go down and posteriorly posterior to anteriorly. But I think your approach is from anterior to posterior and high. I think it's useful to remove the zygomatic patch. But like just first case and the second case, like epidermoidal and petrous apex meningioma, if I treat this tumor, I use basically terional approach. I think
Which approach? Which approach?
terional approach. I mean the anterior temporal approach, like
Yeah.
Sylvian approach.
Thank you for your comment, and I think my approach is very suitable for the lesions that lies in a very high position at the midline, just maybe just right around the posterior clinical process. I think that is the best target for my approach. Yeah.
Yeah, I mean, so, if you want to go to the posterior current process, you can go from the anteriorly, like
Okay. I know. It depends on the site of the lesion. If the lesion lies mostly anteriorly of the posterior canal process, without extension to the position that posterior to the clavicle. So maybe you can choose the anterolateral surgical corridor as well. It's very good. It's a very good surgical corridor. But if the lesion lies from the posterior canal process and to the rostral part of the or caudal part of the clavus, maybe my approach is better, I think.
Okay, I understand. Thank you. Any comment or question?
Questions?
Okay, Professor Chao. Sometimes maybe the mastoid air cell is quite big. Do you have some concern for this kind of patient for pre-operative surgical plan to do additional examination to prevent some post-operative CSF leak?
Yeah, thank you for Professor Shubin's question. I think it's a very good question because I just met a patient that who had the CSF leak after surgery. Even I use the bone wax to
cells.
To close the LCS of the mastoid, but the patient still has a very serious CSF leak. So I think because I have heard from some experts who told me that the LCS of the mastoid is not very important in the anterior part. Maybe maybe the opening of the LCS of the mastoid at the posterior part may cause serious bad results, just like a CSF leak. So after the patient, after the happening of the CSF leak of the patient I just mentioned, I think the anterior part of the opening of the anterior part of the LCS of mastoid is very important is also very important. We need to take very we should to we should how to say, please forgive my poor English.
So I think it should be a regular concern before surgery.
Yeah.
So what's your opinion, Takashi?
I totally agree with you. Bomox is very nice to close the air cell. I think it's enough. Bomox it is. Even if the posterior part, I think. But as you said, posterior part of the muscle air cell, I usually use fat, abdominal fat.
And
actually, I think maybe you can sometimes if you are not very confident to sear the mastoid cellular. Actually, you may use some ACL. You can use some posterior part of the temporal muscle to fix it.
Yeah.
We have Ben from Hong Kong who has joined us. Yes, Ben.
Yes. Yes. Hello, Professor. And just Professor Shubin mentioned about the CSF leak. I have the same question for you. I just wonder because sometimes for those big meningioma, we also want to reset the dura. So sometimes I saw that when you open your wound, you turn the scalp and the muscle together. So do you usually separate them so that when you firstly you dissect the scalp and then you get the temporal fascia, which is posteriorly based, and then you elevate the muscle after you get the fascia. So in that way you could repair the CSF leak. Is that what you can do during the surgery? Another question is that about the during your wound exposure, how anterior the zygomatic arch would you remove? How do you decide on that? And I saw that some of your cases is actually quite extensive skull-based meningioma involving the infratemporal fossa, which could extend into the sphenoid sinus. So sometimes we also get a CSF leak from that site. So how would you repair the sphenoid sinus when you do this approach? Because the distance is quite long. The cavity is quite deep. Yeah.
Okay.
Thank you, Professor.
Thank you for your question. I think by using the deep fascia flap, deep temporal fascia flap is a very useful method to fix to close the opened L cells of mastoid. But if you try this, you will find it's not wide enough to cover all the opened L cells. So maybe just like Professor Shubin told, we can use some pediculated temporal muscle to cover the open mastoid L cells. Is a very good choice. And for the extension to section the zygomatic arch, I think for traditional subtemporal approach, we needn't to go very anteriorly to section this to section the zygomatic arch. I think the size for section is just anterior to the zygomatic arch root. That is enough for the subtemporal approach for to treat the lesions that around the posterior clinoid process and maybe the max cave and the petrous clever lesions. That's enough. But if you want to retract the temporalis muscle more anteriorly, so you want to retract the temporalis muscle more anteriorly, you need to remove a little bit anteriorly part of the zygomatic arch. It depends on the lesion site. If the lesion lies more anteriorly, so you need to remove to section the zygomatic arch more anteriorly. I think this is the answer. And for the repair of the CSF leak of the sphenoidal sinus, I think just like you mentioned, we always want to resect the dura of the meningioma that will cause a very wide hole to cause the CSF leak. I think if we have the chance to open the sphenoidal sinus, we should use the graft of the other side, such just like the fasciolata or the fat from the leg. And first, I think maybe we should suture with the proline suture with the fasciolata to close the dura deficit. Second, we should use the fat to remove the surgical cavity, to make the surgical cavity closed. I think these two methods is useful for prevent the CSF leak. Even by doing so, the CSF leak happened. Maybe we can go from the endonasal approach to maybe you can use the your septal the septal flap to protect. I think I will do this method. Thank you.
Yes, thank you so much. Very comprehensive.
Thank you,
Professor Chao. Actually, I think it's a good idea to harvest the integrated the posterior part of the temporal arch with the temporal bone together. But the really useful part for this incision actually is the inferior part. Superior part normally it's useless. So maybe you can create an even smaller incision and maybe combined with the endoscope. Ben works with a very experted Hong Kong. They focus on the endoscope.
Thank you.
Very nice incision. Yeah, and maybe you can combine with them.
Okay, thank you, Professor.
Thank you very much. It was indeed a wonderful presentation and we learned a lot today. May I invite Professor Takashi Sugawara to close this session with his expert comments.
Okay, Professor Chao, I'd like to thank you again for your valuable time and your showing educational and insightful videos and your beautiful surgical technique. I look forward to having you with us and for another session in the future. Thank you very much.
Thank you.
Thank you very much. So may I close this officially now on behalf of the Education Committee of the ACNS. and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Ajay Waklo and Professor Chao Tianji, as well as the chairs, Professor Shubin and Professor Takashi Sugawara, for the time and support for the ACNS webinars. I would like to sincerely thank Professor Shubin for broadcasting this on the WeChat channel. And as he mentioned, more than 1,400 people have joined us. A special thanks to my co-host, Dr. Lubun Singh, for joining in me today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining.